Marcello Piso from Miami, Mount Sinai, Miami. Hope that maybe when I get down there, I can come visit. I'm down there in Miami quite a bit visiting my grandson. I'd like to come by and look at this technology. Jeff Light basically did an introduction already to you, Director of Perfusion and Comprehensive Care Services, Mount Sinai. Your topic is a new option for whole blood viscoelastic testing, and I can't wait. I've already got a million questions, being that's what I love. So, are you online?
I am. Can you hear me?
There you are. Okay, thank you.
How are you? Thank you for the introduction. My name is Marcello Piso, as I was introduced. I wanted to disclose that this case review has received support from HemoSonics in the form of a speaker's fee. Also, I thought it would be great to start with two quotes to start today's talk off with. Never be complacent about the current steps. Don't agree and follow the status quo. Be determined that you are making an indelible impact with great change. And second, the amount of respect that an idea deserves is revealed by the verifiable facts that it contains. I leave you with this question. Can we equate these quotes to the actions we take when transfusing patients based on the evidence we have? So the narrow window and why. It's important to first understand why we need viscoelastic testing. You see, in the immediate post-bypass period, the surgeon is assessing his work as well as the patient's endogenous contribution to hemostasis. As we all know, some patients come in already challenged by the effects of their medications. This, coupled with the hemodilution and prolonged bypass times, may exacerbate their already tenuous hemostatic status. So the perfusion team can play an integral part in the decision-making process by providing concise and direct communication to the surgeon about the results. This is critical in that the longer it takes for a decision to administer product results, the longer it takes to acquire those products, and ultimately increases the overall OR time. And we all know that time is money. Do we have time for a test that won't provide timely results or requires extensive training and memorization to interpret the results and then provide the surgeon with the information so they can make the decision? Well, the Quantra Plus system delivers everything we need. For our team at Mount Sinai, we use the Quantra Plus. It's a next generation ultrasound-based viscoelastic testing analyzer for point of care use. It's a closed cartridge system, fully automated, and delivers actionable results within 15 minutes. It's very easy to use, and the interpretation is unbelievable because of the beautiful screens and dials they provide us. The information derived from the Quantra is the clot time, the heparinized clot time, which allows us to see the clot time without the effect of heparin, clot time ratio, or calculation between the ratio between the clot time and the clot time heparinase, and this tells us about the residual heparin on board. It also tells us the clot stiffness or the strength of the clot, while providing us with both the contribution of platelets and the contribution of fibrinogen. Ease of use and methodology. There are 3 points or intervals for collection of samples. As there is no additional collection time than what we already experienced with ABG and ACT, we collect that sample at the beginning with the baseline and ABG from the anesthesia. And then on our normal routine rewarming sample, as well as at the end of postprotamine, we receive another sample from anesthesia. As you can see in the video, the Quantra is a closed system. There isn't any pipetting or dripping of blood into the testing analyzer. There is more exposure with the ACT than there is with the Quantra. Once you press start, it's plug and play. So let's look at a case. The following are the baseline results from a re-op AVR-MVR enclosure of an ASD. As we all know, these cases have a higher propensity for blood usage. The patient's baseline ACT was 146 seconds. The H&H was 11 and 35. Baseline platelet count was 396. INR was 1.1. And the patient on this baseline, it showed the clot initiation to be in the normal range, which appeared adequate for hemostasis. Clot stiffness showed robust status with considerable amount of hemostatic reserve. And the communication we provided the surgeon was that normal clot time with hypercoagulable state. Oh, by the way, we got these results in 13 minutes and 9 seconds. Second sample we did was the rewarm on pump time. As expected, the CT showed us no clot detected due to the patient being fully heparinized, and this correlated with an ACT of greater than 600. We also took off 3 liters of fluid for this patient based on the amount of cardioplegia we delivered, so I don't think hemodilution really factored in much with the other parameters that we had. The CTH was prolonged over the baseline. That was expected due to hemodilution. Heparinization was neutralized but not reversed. I think it's important, the clinical judgment of how prolonged the CTH is, because it's 191 now, but from 139, you can explain that it was from either hemodilution or other factors involved, but it is coming back down to normal. So if we had a value of 255, that might indicate the need for us to assess for FFP. But like I said, the result of 199 on bypass, you would need to use further judgment of whether or not you were going to recommend FFP later. The on-pump sample allows us to plan for product to call and get it ready. Okay, this is a great screen. I think people will like to use this screen a lot in their analysis because this is gives us trends. And on this screen, it shows the data from the 2 samples we've taken so far, the baseline and the rewarm sample. From this screen, we have decided to make a simple calculation of the % drop in the clot strength, the platelet contribution, and the fibrinogen contribution to that strength. This patient started above the normal range, but had a drop of 25% from baseline in their clot strength, a 24% drop in their platelet contribution, and a 10% drop from their fibrinogen contribution. This, we found, was a very valuable way to communicate with our surgeon prior to termination of bypass. As you see, the patient is still technically within the normal range, but as we all know, all patients' results are specific to that patient, and we'll talk more about that in the next slide. The postprotamine sample. So the patient's ACT was 122, hematocrit jumped up to 26. Bypass time was 173 minutes. The surgeon observed oozing. So when we look at the values, the clot time, or the CTH and the CT are yellow, indicating they are outside the reference range. But if you remember, we had the CTH of 191 on the rewarm sample. And so we are now trending back towards the patient's baseline, and the CTR is below 1.4, indicating no residual heparin. The clot stiffness shows there's considerable decrease in clot strength. There continues to be a loss in both fibrinogen and platelet contribution, but a notable drop in FCS from the prior sample. The communication we provided to the surgeon was there was no indication of residual heparin, but there was an overall 30% drop in the clot strength. The platelet contribution to that dropped by 30% and the fibrinogen contribution by 40%. So the decision by the surgeon was 1 platelet and 1 cryo. The surgeon's observation of the patient's bleeding combined with the Quantra indication allowed us to move in the direction as stated. Next screen. Prior to leaving the OR, it was decided that we would perform an additional Quantra assessment to ensure that we had the desired response to the administered products. The clot time, the CTH and the CT continue to trend back towards baseline without FFP. Clot stiffness, or the overall clot strength, starting to trend back to baseline. The platelet contribution has leveled off with 1 dose of platelets, and after 1 dose of cryo, the fibrinogen contribution has started to trend back toward baseline from the 40% loss. The bleeding has stopped, and there's confidence going into the ICU that the targeted therapy has optimized this patient's hemostatic balance. In closing, viscoelastic testing has been discussed in the literature to be valuable information when compared to the classic PT-INR. This due to the viscoelastic testing's ability to give you real-time measurements of whole blood versus a PT-INR that may be days old or would take too long to result in the middle of the case or post-procedure when we need to make those decisions. So I opened my presentation with 2 quotes, and we'll again repeat those quotes and would like you to reflect on those when thinking about your current approach to hemostasis management if viscoelastic testing is not a tool in your toolbox. Never be complacent about the current steps. Don't agree and follow the status quo. Be determined that you are making an indelible impact with great change. And the amount of respect that an idea deserves is revealed by the verifiable facts that it contains. This slide shows the images of the results from 3 commercially available analyzers. From the first 2, the results can be complicated to interpret if you don't receive specific and ongoing training. Our team feels that the Quantra is easy to interpret and visually intuitive screen, and names and the parameters are easily associated with the targeted products. HemoSonics, again, the great thing is that they've provided unparalleled clinical support to our surgeons, the anesthesiology team, and the perfusionists to better manage the hemostasis of our patients. And in closing, how will you decide which VET platform you will utilize? I say VET is easy as 1, 2, 3. It's easy to run, easy to interpret, easy to execute, communicate, select, and administer. Thank you.
Thank you, Marcello. I got several questions. First of all, I mean, you might be hearing a train in the background, but on the rewarming phase, even with the tag, I basically studied the tag for 30 years now, and I just don't understand the rewarming phase because I really don't feel like a rewarming phase is necessary. And I think your coagulation system, when you're doing blood management, is going to be completely different in the post-protamine stage. And even with your device, I feel like it would be the same. But also, I'm curious. To me, every patient is a little different. In other words, a 60-pound little 90-year-old lady is not the same as the 220-pound national athlete, and their coagulation status is different. So, how do you know up front what the normal status of that patient is, and the transfusion? It's a completely different scenario when you base it on the tag. And I mean, I think your platform is unbelievable. I'd love to see it, but how do you come up with a transfusion algorithm, or do you have a transfusion algorithm based on the platform of your device? So, is it FFP? Is it cryo? Or maybe you could add DDADP. So have you compared, or maybe you need a little bit more protamine, as we've seen. Have you done those studies, and have you compared it directly to, the tag system in the thromboelastograph?
So I'll start off by saying that unfortunately, it's not my platform. It's one I use because I'm a clinician. But I think that from a planning standpoint, I was very skeptical, I'm not going to lie, about a rewarming sample to see what value that would bring to us. But I think when you look at the trends screen, which is the second one, I don't know if we can bring it back up at some point, but the trend screen shows you where things are going. And so you may not at that point say, okay, we're going to order FFP, or you're going to order cryo, or you're going to order platelets, but it definitely shows you where we're going and the direction that we're going. So as far as FFP goes, I can tell you that from just using the Quantra, maybe it's empirically or whatever, but our FFP utilization is probably reduced 90%. And, so we primarily understand that it's usually a platelet or a cryo issue. As far as, redosing with protamine, obviously that is not important until after we give protamine. So when we do that final protamine sample, post-protamine sample, we're able to use, we do use the HMS as well. So we take both the CT and the CTH and that ratio that it gives us. And if that ratio is greater than 1.4, then, and we look at the ACT and the HMS, if it tells us that we, or higher baseline ACT than we begin with, and we're greater than 1.4 on the CTR, then we're going to recommend, more protamine. So I think from a standing or from a planning perspective, the machine is great because at least you can say, hey, listen, we're thinking about it. The surgeon's already thinking about it. I don't have to wait for him to be off bypass and say, listen, I'm seeing bleeding, I'm seeing oozing and stuff like this. It gives him in the back of his head. And so we actually came up with the percentage drop, and that's what he likes to hear. And so the percentage drop to him is if it's over 25%, then in the back of his head, he's already thinking, well, what am I seeing in the field? And, which one is the biggest culprit? Is it fibrinogen or is it platelets?
Yeah, I agree. I just don't feel like the rewarming phase is beneficial to anybody as far as ordering blood or blood products during that period of time. My next question is, where do you stand as far as, these patients are coming to our arena now with multiple, platelet inhibitors. Where do you stand as far as can you use your platform for these inhibitors and for people that are on aspirin, Plavix, Plazagril, Bolenta, you name it, where's the platform for that?
So again, I think that if the patient is on any of those drugs already, and this machine's not going to tell us, what their percent inhibition is or any of that stuff, but they need surgery, we're going to give them surgery unless they can wait. Either if they can wait, then we'll wait. If not, that we're going to do the surgery because it's required, and then they're going to buy the products. That's just.
But you don't know how long to wait.
No, you don't. That's, that is not part of this, but if you had the tag, you would have a separate test for that. You would have two different tests. So I don't know what the, platform moving forward is on it, but I'm sure that it's going to be addressed.
I think I can jump in, chime in a little bit here too. Marcello, fantastic presentation. Thank you so much.
Yeah, absolutely. Very.
I know, fantastic. And thank you. I'll tell you we are the new guy in the market, right? And so I appreciate Mount Sinai's willingness to work with us, and I'm very happy that they're happy. We have on the call as well our clinical manager, who is Jeff Huxford, and he's actually quite adept at both Quantra and TAG, based on his professional experience. And as he came over and we started to talk about exactly this, the value of the rewarming sample, and also what to do about the oral antiplatelet drugs, really the platelet inhibitors. We've had so many discussions. I'd love to turn it over to Jeff and get his perspective on this.
Hey, thank you, Jeff. Can everybody hear me okay?
Yeah, Jeff.
Good to see you again, Ty. It's been a long time.
Yeah, it's been a long time.
Yeah, it's been a long time. So first, I'm going to address real briefly the rewarm sample from the perspective of some of our customers, in addition to Mount Sinai and the way they look at it. I would agree that ordering blood products on bypass can be somewhat challenging because that things are going to change when you come off bypass, Ty. So I think it's a fair point that you make. I think the value, though, in addition to the value that Mark did such a good job of explaining, was the fact that, when you got those really long bypass runs and we start to see a fibrinogen drop on bypass, we all know that cryo takes a little while to prepare by our blood bank, even the blood banks that are assertive and really close to the OR. And so being able to give them notice early on to prepare the cryo or prepare the FFP. We all know we can bring platelets and FFP in the room and send those back to the blood bank and they can be used again. It gets a little more challenging with cryo because once we've ordered it, we've bought it. So I think you got to take the situation where it's the really long bypass run where you might consider ordering that product. I think the other two you can order safely, and if you don't need them, send them back. I don't know if you think that's a fair statement, Ty, but that's the way we look at it.
Even TEG basically, with Dr. Cohen and everybody else for a long period of time, and even Dr. Cohen agreed. The rewarm, and we had that discussion earlier today, and several discussions on that, and everybody agreed that pretty much a rewarming sample. I just don't feel where there's a huge benefit because you're basically incorporating so many different blood management techniques during the case. And again, your platform is another key part of blood management. Right. But you're basically concentrating your platelets. You're giving the autologous blood back. You're concentrating that kind of stuff. And when you do that, then you take that measurement, it's changing the whole parameter of what's going on with that patient. So I just feel like it's a wasted. If you're ordering blood products at that point in time, you're basically, as they say, it's a blood bank and so therefore you're taking away from the bank and you're taking away from that deposit, and there's no return. A lot of these products you can't return. And like you said, and again, I just feel like we need to assess the patient post-protamine, and with your platform, it's very easy to do because it's so quick. I mean, if you have a platform that's that quick, why do you need to do a rewarming sample?
So I'd like to chime in for a second as a user, if I could.
Go ahead.
So again, I used the TEG many years ago, and when it was the baseline, rewarm, and post-protamine, and then eventually we did go away from the rewarming as well for all the reasons that you discussed. And so I think it's probably a logical step for us as a user to kind of get through that or to go through that process as well to see where we're going, because like I said, this case showed that we were actually hypercoagulable and that we had very good clot stiffness. So when I told the surgeon, hey, listen, we've had a pretty big drop in the clot strength. We've had a drop in the contribution by the platelets and a drop from the fibrinogen. It just sent an alarm off. Now, I don't know if we'll always do that. We may replace that rewarming sample with the post-product, if we end up giving a post-product sample like we did in this case, to verify that we were justified in giving the product. And that's all I wanted to add in that.
So Ty, if I could add two more things and then move on to your question on platelet inhibition. So not all perfusion departments are created equal. That's not to say that, everyone's not doing the best they can for their patient, but not everybody is as assertive at blood management techniques like the ones you're talking about hemoconcentrating and doing the various things you're doing. So, our clinical team and our sales team are serving a whole host of people. So that would be one thing I would say. And the other thing I would say is there's various levels of patients from surgeons. And I think we can all agree with that, having worked with enough cardiac surgeons. Some cardiac surgeons are ordering blood products the minute they come off bypass because they hear, the suckers bringing a little fluid into the cell saver and they're yelling for blood products. At that point, we use the rewarm sample to say, hey, this is kind of where we're trending, but we're waiting on that post-protamine sample right now. Even though it's 15 minutes, there may be a little bit of wait. 15 minutes may seem like a little bit of a wait for an inpatient surgeon. So it's helped us in those situations too. But I don't want to belabor the point. I do see where you're coming from, Ty. I do want to address your question about platelet inhibition. A normal Kaelin TEG, a normal Rotem, or a Quantra, none of those devices will pick up on platelet inhibition because of the fact that we're using activators that generate thrombin. And I know you know this, having worked
I don't agree.
Okay, well, I will just say that is why the TEG platelet mapping uses heparin to remove the effect of thrombin so that they can then use an activator to look at ADP activation and look at how those platelets aggregate and then determine the level of inhibition. So I would say that unless you're using TEG platelet mapping, a normal TEG, a Kalen TEG, a Rotem, or a Quantra are not going to show that level of inhibition. So in those situations where we know a patient's come to the OR on an inhibitor and we don't assess the degree of inhibition, we can certainly work through the case with the clinician to say, fibrinogen looks good, FFP looks, we don't need FFP due to thrombin generation, your patient's oozing, you know that they took Plavix, you know that they didn't stop taking their Plavix, and therefore a clinical diagnosis and rule out of information and taking all of the clinical information into play with the Quantra, you can make a pretty educated guess that it's probably platelets in those situations. Now, I am willing to admit that there are patients that come to the OR having worked with TEG where you don't know that they're on an inhibitor and you find out when you do TEG platelet mapping. Well, with the Quantra, we wouldn't see that inhibition, but we can certainly go through a series of discussing with the clinician, you know, where's the calcium at? Is it a surgical error? Is it, you know, a temperature error, pH error? We start to go through the whole differential diagnosis. And at some point you get to a place where once you've tried DDAVP and everything else, that platelet inhibition has to be the answer and you move in that direction. So no, we don't assess platelet inhibition with the device. Neither does a Kalen TEG, but a TEG platelet mapping does, and Verify Now does. But we're trying to help people in that intraoperative phase. And
I think that's a totally different platform, and I think that's very beneficial. But I think, you know, that's one of the platforms that you also need, especially in your population today. Again, I am very impressed with the coagulation system, and I would love to come in when next time I'm down in Aventura to visit my grandson. I'd love to come in and just see how the device is used, because I think it's extraordinary. I just feel like, you know, there's some parameters where you need another system involved in what you're doing as far as coagulation.
So I'd like to add to that too. That's a very good point. We do have customers that have kept TEG platelet mapping as their preoperative screen, and then we use Quantra intraop because of the quick turnaround and the ease of use. I think there's a way to marry those two technologies, just to be honest with you.
Absolutely.
Anytime you're down, you can come visit.
I will get in touch with you, Alex.
So that was great. Thanks, guys. Thanks for that. Good discussion. And certainly, I think at the end of the day, we should all acknowledge that there's no diagnostic tool that can do everything, right? Right? Yet we don't have the tricorder.
Yes, absolutely. Is Dr. Spees over in Gainesville, is he actually doing some work with y'all?
As a matter of fact, yes, they are a customer.
I thought he was.
Yeah.
And hopefully he'll have some results, hopefully by next year's presentation. I think he told us last time that he was working with your product.
Yeah, as a matter of fact, so I would encourage, if you are not yet registered for the SCA, he will be presenting preliminary some of those results that you're referring to. So,
Jeff, it's nice seeing you again.
Yeah, you too, Ty.
Good to see you, Ty.
Jeff, thank you.
Thank you very much.
And Marcello, you'll see me soon, man.
All right, great. Thank you.
Again, thank y'all very much. We appreciate every one of you. Anything we can do in the coagulation and blood management is huge. And y'all, these platforms are, I think, very beneficial for the future patient care and outcomes. So again, we're going to end the day with that note.